Good morning, ladies and gentlemen. So thanks, Justin, for the introduction. Thanks very much for being here today. It is an honor for me and for every Symbios people here to welcome you for this meeting. So I won't do a big speech, apart that it's a great pleasure to share our specific vision of orthopedic, which is specific since the beginning, since my father created this company in 1989, on the vision that we could maybe one day try to propose for every patient a very customized solution on every aspect of the procedure, which starts with the planning and of course also probably with instruments and implants. So it is not easy to do it, since the beginning, and it is, I would say, a progressive approach. But now we have on the custom stem roughly 30 years of experience and of, I would say, clinical experience, which is well described and published. And some of you today will also present some work on custom stems and also on 3D planning. So I'm very delighted again to welcome you, and I wish you all a very pleasant meeting. And also I would like to take some words to thank all the members that will speak today for what they will present. Thanks very much and enjoy this meeting.
It's really an honor for me to be here, and so I thank you for this invitation. I would like today to talk about the 3D planning, how I came to it, why I stayed, and I would like to talk and to give my experience. So now we are in 2018. The requirements for total hip arthroplasty, I think, moved on. It's not just enough to remove pain and to enhance function. We are dealing now with younger and younger patients with higher and higher expectations. So we need to restore biomechanics as close as possible to the normal. So to achieve these goals, it's very important, in my opinion, to perform an accurate preoperative planning in order to analyze the 3D anatomy, to forecast, try to anticipate the difficulties likely to be encountered at the time of surgery, to choose the optimal surgical approach, and also to choose the best fitted implants in order to achieve a mechanical stability in the implants, and also trying to avoid some mechanical complications such as perioperative fractures, for example, or early loosening. So the parameters that influence the hip biomechanics, the hip rotation center, and as I said beforehand, the first thing we do, we ream the acetabulum. So we alter this hip rotation center. So this point usually is shifted posteriorly, medially, and cranially. So in some cases, we have to adapt the femoral anteversion such a way these 2 points, which means the center of the ball and the center of the acetabulum, should be spontaneously coincident. When we have these 2 points coincident, it's very difficult to get dislocation unless we do a huge traction and distraction. So when we analyze the center of the femoral head, there are 2 main components. The distance from the top of the great trochanter, which is correlated to the length with all the risk of legal actions because of lower limb discrepancy, and also the distance, the femoral offset, this distance from the center of the ball to the femoral axis. And we know that if we have a decrease of 15%, we may have some gait alteration, and if we have more than 28%, we have a much higher risk of dislocation. And finally, the acetabulum and the acetabular and the stem anteversion, they have to be restored. So I like to see, in the 3D planning, I like to do this drawing. I mean, it's from the top to the bottom of the patient, and we can see the acetabular anteversion, the femur or stem anteversion, and finally, the foot rotation angle. And this parameter has to be also included in the analysis, because in a young patient, when he wants to do sports, this angle has to be restored. So until now, the gold standard, according to the American Academy of Orthopedic Surgery, the gold standard for planning is this. It's a 2D planning. It's either if with template or digital templates, it's this. And for me, it's very difficult to analyze it, to take into account all the parameter we talk about just beforehand, just with an X-ray. Why? First of all, there are many limitations. The first limitation is that the accuracy of the 2D planning now is clearly demonstrated. It's twice lower than the 3D planning in terms of determination of the component size. Second of all, the 3D planning is twice more accurate when trying to restore the length, as you can see here, the femoral offset, and also the center of rotation. Because when we start using 3D planning, we adapt our reaming procedure to what we see. And we will have some examples afterwards. The other limitation of the 2D templating is the fact that we always tend to underestimate the femoral offset when we analyze it on the X-rays. This paper published some few years ago in GOA showed that indeed the 2D values is lower by in average 3 millimeters to the 3D values because of the anteversion, and also because these patients with osteoarthritis, they have pain, and they have very often stiffness with an external rotation of the hip, which is fixed. The third limitation, we don't assess with the 2D plan templating the mechanical properties of the bone. And the easiest way to get it is to analyze the Hounsfield density of the bone. For example, here I put two examples. On the left, an old femur, let's say an 85 years old female with an empty femur only filled with fat, and you can see the density is negative, -15. And on the right, a young femur. So on the left, I very often use cemented straight stems. On the right, I prefer to use cementless stems and sometimes anatomic or custom. Finally, another limitation of the 2D templating is the fact that we don't assess before surgery the acetabulum anteversion and the femur anteversion. And you can see here, this is the paper published in the JBJS British in 2009, and we analyzed 223 patients with primary osteoarthritis. There is no severe dysplasia in these patients. And you can see that the acetabular anteversion ranges from 0 to 50. So if we try, for example, to always put a 15 or a 20 degrees of anteversion, we may have, for some patients, it will be not enough. They will dislocate posteriorly, and in other patients, they will dislocate anteriorly. So we have to adapt the acetabular anteversion to the patient. And the same thing for the femur. It ranges from 0 to 50. So if we always aim the same value of 20 degrees, let's say, for example, we navigate the hip arthroplasty, we may have some troubles. With the 20 degrees, we can either have anterior or posterior dislocation. And I have a colleague, when he started to use 3D planning, for example, and he found that the femur anteversion is, let's say, 45 degrees, he said, oh, it's too much. Let's try to decrease this femoral anteversion and go back to a standard normal value. And he started to get posterior dislocation, despite the fact that he was using direct anterior approach. And finally, the limitation that was also for the 2D, in the 2D templating is the assessment of the lower limb discrepancy, because usually we do it on pelvic X-rays, and when, for example, some patients are longer on the operated side, they will tend to stand up with the flexum of the knee, and so the lower limb discrepancy may not be detected on the X-rays. So now let's speak about the 3-dimensional planning. This is why I moved on to 3-dimensional planning. The first step is to analyze the leg length discrepancy, and we know that leg length discrepancy is composed of two components. The first one is intra-articular lower limb discrepancy, corresponding to the wear and dysplasia. We may have coxavara on one side and the standard femur on the hip on the other side. And the extra-articular lower limb discrepancy corresponding to what we call the segmental length. And for some patients, for example, they have a longer tibia or a longer femur, for example, if they have a disease or if they had a fracture during childhood. And in our experience, 34% of our patients are longer on the operated side. And these patients don't tolerate any kind of lengthening. Let's say they have 8 millimeters more on the tibia, and we add 5 millimeters in the hip. because it was a VARA, for example, 8 plus 5, we will reach 13. And when we go up to 1 centimeter, people really don't feel well. In some cases, complicated cases like this one, it's very difficult to analyze into the lowering discrepancy, and this is why we always compute this in 3D in order to get a more accurate assessment of the lowering discrepancy. And also in these cases, I did not put any slide of it, but we take also into account the spine, because in some cases, in some dysplastic, severe dysplastic hips like these ones, they very often have a slight scoliosis, so we have to take into account the global length of what we call the global functional length. And this had to be computed in 3D. Now for the length, what are the goals? I would say we recommend to correct only the wear and the dysplasia. For example, when a patient is longer on the tibial side, for example, we never perform an intra-articular shortening. Why? Because the shortening, it may lead to dislocation, it's true, but now with the large head diameters, the dislocations become, it's not as frequent as before, but we may have edge loading. So you can see here, this is a 3D model I developed during my PhD thesis, and you can see that if we have some kind of laxity of the hip, at the time of the swing phase, we may have the head and the cup that separate. And after the heel strike, we will have a contact between the ball and the edge of the cup. And this is dramatic. This is what led to the failure of the large-haired middle hips. And also we may have fracture of the ceramic, squeaking, and sometimes some pain. And people feel this. The patients feel when they have edge loading. The next step is to analyze the bone density and the femur morphotype. For example, here on the left, you have a stovepipe femur, let's say an aged femur, with a completely empty femur. The bone density is -14, with no flares, no anterior flares, no medial flares. So in this stovepipe femurs, I would tend to use a straight stem, which probably I will use a cemented fixation, with cemented fixation. Now, here on the right, you will see it's a femur of a young patient with a very hard bone, a density of more than 200, and with very high flares and curvatures of the femurs. And in these cases, I will tend to use an anatomic stems like the SPS1. And in some cases, if the flares are very important, I will prefer to use a custom stem. Now the Nobel's index, you all know the Nobel's index. And so when we analyze this Nobel index, you can see that for a normal index, I will tend to use a standard stem. In the stovepipe, I will tend to use a straight stem or any kind of cemented stem. And in the champagne flute, some people would say the door A femurs, I will tend to use either an anatomic stem, or when we have very large femurs, with very important flares, I would tend to use customs in order to achieve a fit. Because in my experience, using a straight stem, like I would say, I would not give any name, commercial name, but you all understood the stem I'm talking about. When we use a straight stem in such femurs, we may have some early failures. It will not be in the first year. It will be in a failure after 6 to 7 years follow-up. So now for the 3D cup planning. So we have 3D templates. So we are able to determine exactly the optimal size of the cup. Such a way we will avoid, for example, any kind of impingement with the psoas muscles, and also any kind of oversizing. So we always consider we put the cup. We will try to seat the cup on the medial wall. We will try to restore the native anteversion, unless, of course, it's a dislocated hips. And in this case, if we have a major dysplasia, we will tend to use the symmetrical point comparatively to the contralateral healthy side. Now, in order to see and to determine whether this position will be stable or not, we use a color mode which reflects the density of the bone which is in contact with the cup. And we consider that in order to be stable, this cup had to be seated on the hard bone, which means at least 200 between 2 and 400 unit field density, at least on the two horns and somewhere on the roof. And it's very important for us to get at least 40% of the cup in contact with the native bone. Now, we can use also 3D visualization tools in order to visualize the final position of the cup within the acetabulum. So for example here, this is a paper we published last year in JBJS American. And we use this technique, which means that we can measure the distance from the edge of the cup to the edge of the acetabulum. And this very easy technique helps us to really improve the accuracy of the cup positioning. And we also decreased the percentage of outliers regarding the cup positioning technique. Now for the stem, it's very powerful to do 3D planning because we are able to analyze the fit and the fill of the stem within the femur in all the planes. I mean, the axial, the coronal views, the sagittal views, the axial views also, and we can do it in whatever plane. So we will choose, I would say, the shape and the size of the femur according to the geometry. So the goal is to achieve, to maximize what we call the fit and fill of the stem within the femur. And once we have determined the size, it's very important to know where this stem will be seated. And this is why we use this color mode, which basically is an integrated view of the stem within the femur. And it allows us to see where will be the contact between the stem and the cortical. And for example, here for the SPS stem, which is an anatomic stem, you can see that the contact will be proximal in the metaphysical part of the femur. So it's very important for us to optimize the fit and fill. Now, once we have simulated the cup implantation, the stem implantation, now we have to optimize the reconstruction of the hip anatomy and on the extra medullary part. So this is a very important step, and we use a library of stems because now we are no longer able to use modular stems in our experience because of historical reasons. So we use a library of stems. Monoblock stems, it could be an anatomic, SPS anatomic stems in the young patients, or straight stems, like I would say Corail-like stems, or sometimes cemented stems, like the Müller straight cemented stems or some Charnley stems. We use also modular femoral heads, -4, 0, +4, +8, and the goal is to restore the limb and the offset. Sometimes it's not feasible to restore all these parameters. So if it's not feasible, this is when we go for a custom stem. So it's an evidence-based choice for the custom stem or not. So for the offset, what is the goal? It's not to restore the femoral offset, but to restore the global offset. Sometimes, for example, we have to shift medially the cup because of dysplasia, as you can see here. And when we shift medially too much the cup, we will decrease the acetabular offset. And in this case, we may create a laxity and a risk of dislocation and edge loading. So in this case, what we do, we increase the femoral offset such a way the global offset will be kept constant. For now the anterior version, usually we tend to restore the native femoral anterior version. And sometimes we have to adapt this anterior version. For example, here you can see this example. We shifted too much posteriorly the center of the hip rotation, so we have to decrease slightly the femoral anterior version in order to make these 2 points coincident. You can see here, for example, if we use a straight stem with the straight neck, there will be a tendency to an anterior dislocation or edge loading. With a retroverted neck, it would be perfectly stable with no edge loading. And this was checked at the time of surgery. Now, the question is there a need for custom femoral stems? In my experience, yes. This is why I do things so, because I always try to perform a proximal metaphysical fixation because we are dealing with younger patients with longer and longer life expectancy. So the short metaphysical fixation is a very attractive option in order to preserve bone, to achieve more proximal load transferred, and to limit the soft tissue damage. The problem is that with this short fixation, the overall survival rate is yet still not satisfying. And with early mechanical failures, with subsidians, stress shielding, femur thickening. So why? Our hypothesis was that these early failures for the short stems, well, I would call them the short fixation stems, like the anatomics ones, is due to the fact that there is a very high variability of the metaphysical part of the femur. And so it's difficult, it may be difficult to achieve a correct fit. Let's see the difference between these two femurs. On the left, these are two young patients. On the left, I would say a standard femur. On the right, a round femur. It's extremely difficult to use a cementless stem which will be stable in such round femurs. So this high variability, we have already reported this in the clinical orthopedic rates and the related research in 2012. And comparatively to the standard femur, you can see that the varus here and the valgus have really different metaphysical part of the femurs. So when we analyze here, let's say this is a view from the top to the bottom of the metaphysical part of the femurs. We took slices and we analyzed the volume of the metaphysical part of the femur. You can see here the standard femur. In the varus, you will have a very high medial flare with a tendency to a retroversion of the metaphysical part of the femur, and this generates a spur. This is why in some varus we may have a risk of fracture when we use some standard stems. In the valgus, it's the opposite. We have a higher lateral flare and a tendency to an antitorsion of the metaphysical part of the femur. So when we compare the three femurs, you can see this standard, varus, valgus. The same volume, but three different shapes. It's hard to believe that we can implant the same stem in these three different femurs. So we can see that we need some time to adapt the shape and the orientation of the stem. For example, here you have these femurs with a slice 2 centimeters above the left trochanter, 1 centimeter, and the middle left trochanter. You can see here that if we really want to perform a proximal fixation with a good fit and fill, you can see here that the orientation, the shape of the stem should be adapted here, here, and here. So we get a kind of torsion of the stem and also an adaptation of the shape. So we did this study, and our hypothesis was that when aiming for a metaphysical fixation and aiming to perform an accurate 3D reconstruction after THA, we may need some custom stems. So the goal was to determine the percentage of patients requiring a custom stem. And we wanted also to assess midterm clinical results. So from 2008 and 2014, I performed 10 consecutive patients with the primary total arthroplasty using always a direct anterior approach and always a 3D planning with the HipPLAN. And the results were quite interesting because a custom stem was absolutely required in 72 patients, which means 12%. 40 female, 32 males, mean age 48, so younger patients, of course. And in 12 cases, these patients had a previous surgery. So previous surgery, modified femurs. Sometimes we have to remove some interior fixation, some plates, some screws. So it's very difficult to perform the surgery sometimes. You can see that these patients had very low hip scores before surgery. And what were the etiologies? First of all, severe femoral torsional abnormalities. Coxavara with high offset. So it was performed in order to restore simultaneously the femoral offset in the lower limb. Long necks, it's not vara, but high offset with long, very long necks. Coxa valga, in order especially to avoid a fracture, because when we use in coxa valga standard, I would say standard stems, very often the curvature of the medial part of the stem doesn't fit the medial flare of the femur. Very small femurs also, and sometimes we did it in order to achieve a correct fit, an optimal fit in order to increase the primary stability and also to avoid a fracture. So here's some examples. This, it was a 32 years old female. So here's the X-ray. It didn't seem so difficult on the X-ray. It was a true small femur, a very narrow femur, but it was not. It didn't seem so difficult. But when we analyzed in 3D, we saw that there was a very important torsional abnormality. Difficult to see where is the coronar frame, where is the coronar frame, and where is the sagittal frame. So we did a custom stem. We corrected here. You can see that the torsion of the proximal part of the femur, it was 63 degrees. And this is the final X-rays. We did it through a direct anterior approach with the minimal invasive surgery. So these custom stems allowed us to do a very difficult case using a standard minimal invasive surgery. So this is the case, and it's very important to see that, for example, when always we tend to analyze the anterior version like this, you know, this angle between the BCP, the bicondylar plane, and the axis of the neck, this is the anterior version beta. The problem is when we remove the head at the time of surgery, there's no longer any kind of anteversion. With what we have to deal with the orientation of the metaphyseal part of the femur, what we call the helitorsion. And this helitorsion theta is usually higher than beta. And the more the dysplastic is the hip, the more is the difference between theta and beta is higher. And sometimes it's 20, 30, 40, 50. It was 60 degrees for the previous case. So the risk is to get dislocation, anterior dislocation, or to have a patient who will walk with an internally rotated foot. And this is extremely, this is problematic because we cannot do sport. We can walk, but we cannot run, and we cannot do sport or high physical activities with such foot turned internally. So what the easiest solution is to use this custom stem. So we adapt the shape perfectly, and afterwards we retrovert the neck in order to correct the anteversion. And we managed to get, a very nice result quite early. When we do extended trochanterotomy, we don't get this at 3 months. Impossible. Another case of DDH with a severe torsional abnormality. In this case, the anteversion was of the helitorsion. Sorry, the helitorsion was about 90 degrees. So the difference between the orientation of the metaphyseal part of the femur and the final center of the femoral head, it was about 75 degrees. 65 degrees, sorry. So this is the case with the graft, nice X-rays with this custom. Here it was a severe virus with the patient with 130 kilograms per weight. So we use a custom such a way we restore the femoral offset, and also we avoided to use modern necks. A coxavara with a very, it's not really coxavara, but a very high offset. Sometimes we deal with patients who have 60, 65, 67 millimeters of femoral offset. It's impossible to restore this with standard stamps. Here, it's a coxavara with a narrow femur and the torsional abnormality. Very often, the coxavara don't have only a problem of femoral offset restoration, but also they have a torsional abnormality. So in order to restore the anteversion and to restore the torsion of the foot, we need to use this such of customs with a retroverted neck and a nice reconstruction and a very nice result. Here, a coxavalga with the torsional abnormality also. You can see that the neck is retroverted relatively to the shaft. Here, it's 17 years old male with a femoral dysplasia. He had a Lobstein disease and with a very high risk of fracture. So we performed a custom stem in order to maximize the fit and the fill, such a way there is no punctual contact. The contact will be distributed over a huge surface. And this was the custom. This guy now is 23. He's living in London. He's having a great success in his job. He's an architect. And really, I'm very happy because we managed to do a cementless stem in this very young patient. This is a case of a dwarf. Okay, he was something like 135 centimeters height. And in these patients, we had a very high accuracy for the center of rotation, length, and offset restoration, about 1 millimeter plus or minus 3 millimeters. So it's very difficult for me to imagine that we can do better than this. The anteversions of the cup and the stem was restored with the high accuracy, with no significant difference between the planned values and final values. And the midterm outcomes were excellent, with the 93 points for the Harris score, 56 out of 60 for the Oxford HIP score. So excellent result, despite the fact that we had to deal with complicated cases. So just to finish, to say that when we use this 3D planning with, we can achieve excellent outcomes, and especially the outcomes will be reached quite quickly. And so I would say that as a conclusion, a short metaphysical stem fixation requires a 3D planning of the hip. For me, it's very important to do this, a 3D planning. In order to ensure simultaneously a good metaphysical fixation, fit, and fill, and simultaneously also to perform an accurate 3D reconstruction of the hip, we need a custom stem in 12% of cases. And we managed to achieve excellent midterm results despite the fact that we are dealing with very difficult cases. Thank you.
Thanks very much. Can I start off with the first question about acetabular positioning? I think a lot of people in the room here will have been brought up on David Beveland's literature and be positioning their acetabula parallel to the transverse ligament. When you do your 3D planning, how accurate is that? Can you reassure us that doing something relatively simple like that ties in fairly well with your more sophisticated techniques?
Yeah, when we do the 3D planning, we need anyway some kind of guidelines. I mean, it may be either what I showed you, the 3D visualization of the cup within the bony frame, and measuring the distances from the edge of the acetabulum. This is extremely, extremely accurate. Not as accurate as it might be with some guidance systems. It's possible to do this, to design some, and Symbios is up to do this. They can do this, to design some guidance systems, that will show you the final position of the cup within the bony frame. So it's accurate, but it's true that the standard deviation it's still something between it's 6.5 degrees. It means that sometimes if you don't measure accurately, the distances from the cup to the edge, you may have some difference of about 10 degrees or 15 degrees from the planned values.
But when you look directly at the transverse acetabular ligament, how often is the edge of your cup parallel to that, and how often
it's very different. It's extremely variable, because to be parallel to the ligament transverse that have been described by Beveland, in my experience, when we try to do this using the anterior approach, we tend to antevert too much the cup. Because I try to do this to align to the Beveland ligament, to the transverse ligament. When using the anterior approach, we will tend to put easily 15 degrees more than the natural anteversion. So this is why I'm very cautious about this ligament, especially when the anatomy is really modified. It may be difficult to get it right with this technique. This is why I prefer really to measure the distances from the cup to the edge of the acetabulum. And for example, I noticed that people who moved from the posterior approach to the anterior approach, they will tend to antevert too much their cup. And this is why, for example, sometimes I modify the positioning of the patient on the operation table. So I can't really rely on the position of the pelvis. So this is why I always take a local referential. So I would say, yes, this is reliable to measure the distance from the edge of the cup to the edge of the acetabulum. And I will not really rely on the transverse ligament.
Okay, thanks. Some food for thought for me there anyway. Thank you very much.
Pleasure.
And we're going to have a cup of coffee before we move on.